So on behalf of the Selective Mutism Association, we wanted to talk a little bit today about using telehealth for selective mutism, given everything that's going on in the world today. We're hoping that this might be a useful conversation to learn from and to be able to guide some of your practices in the new age of telehealth regarding working with clients with selective mutism. So we put together a panel of some amazing experts. So we have Rachel Busman from the Child Mind Institute, myself from Florida International University, Aileen Herrera, also from Florida International University, Steve Kurtz from Kurtz Psychology, and Katelyn Reed from Thriving Minds Behavioral Health. So welcome everybody.
Hi. Thanks.
So we're going to jump right into it. So I'm going to be asking some questions, kind of leading this panel, and we really wanted to get you some kind of the nuts and bolts of doing telehealth and also talk through some of the difficulties that can arise. So just kind of putting some things out there to start, what are some of the main platforms that you guys use at this point in time, and why are you using them? What are some of the pros and cons of using them?
I'm a Zoom guy now, having cycled through many others, and what I like is that the patients can use the same link every time we meet, that all the participants can use the same link, and that I can hold people in the waiting room. So if my 3 o'clock runs a little bit over and my 4 o'clock is there, there's no HIPAA violations because I can kind of have them holding out and I can record the session. So those would be some of my top pros for Zoom.
Yeah, great.
I agree. We are also using Zoom, and we're using Teams for some of our internal meetings and case consultation and things like that with outpatients.
Yeah, same for us. FIU is using Zoom as well.
Yep. Katelyn, is there any other platform that you guys are using at the current moment?
We are also using Zoom. We are also using Zoom at Thriving Minds, and I'll just volunteer that I have the app on my phone, and one of the new fun features that I've discovered is that you can put like a photo, so this morning I spent the day next to the Golden Gate Bridge. So it blurred out my background and everybody could just see me by the Golden Gate Bridge, which was kind of fun.
Yeah, they have some really neat virtual backgrounds. We we had discussed prior to that some people were using Doxy, which was also another kind of HIPAA compliant platform. And so none of us are currently using that, but we wanted to put that out there in case you can't get Zoom for some reason, but I think they were really trying to make a lot of that accessible for other people. I think the other neat
WebEx too. Are you thinking WebEx?
Yeah,
because it's been used before.
We were using WebEx for quite a while at FIU. And the neat thing about, I think, all of these platforms in particular is that they have a great share function. So you can always go in and share, just like we're sharing with you today. We're all talking to you, but we're also sharing our slides with you, and you can go in and share the documents you're working on. You can share something and actually pass the mouse back and forth to one another. And you can also, there's some of them have the whiteboard function, and you can draw and write and circle just even on within the teleconference. So it's really nice. And Katelyn, maybe you can update people on sort of some of the standards that are happening right now regarding telehealth.
Yeah, so it seems like it's really rapidly changing. One of the things that the Department of Health and Human Services has recently unveiled is that they have relaxed some of the standards for telehealth, meaning that we don't have to use services that are HIPAA compliant right now in response to the COVID-19 outbreak and kind of the necessity to get people access to quality mental health services. They've gone ahead and relaxed those. So people are able to use FaceTime and I can't think of any other platforms right now, that Skype, things like that that are not currently recognized as HIPAA compliant. We are able to use those in a way that we have not been able to before. I think probably best practices are still use the things that we know to be, HIPAA compliant. But if you're in a pinch and the family can't, have access to something that you would recommend, you can use those services now too.
Yeah, I think as long as you're using it in good faith, like they're gonna sort of waive all of those sort of violations, which is just so they know that we got to get these services out to people in some fashion. So Yeah, that's great. And I think also, you know, we have some resources listed at the end of our presentation that we'll also be uploading that you can download for free. And on the APA website, they give a lot of great suggestions on consents for telehealth services, just so that you're documenting that they agree to be on telehealth with you, or even if you can't have that, but you're documenting somewhere that they have agreed to go onto a telehealth platform with you. And that you're doing the best that you can to be as confidential as you can with them. So as long as you're documenting that, that would be great. And Steve, you've had some great expertise lately, kind of figuring out sort of the jurisdiction laws and going between some states. And so we were going to have Steve talk just a little bit about obtaining some waivers of jurisdiction.
So just as a basic reminder, if you're licensed in New York, you need to be, and you have a patient in New Jersey, Connecticut, Wyoming, wherever, you need to be licensed in that state as well. And what's been happening this past week is that certain jurisdictions are making it possible to practice without any notification to the state. So for example, in Connecticut, if you're licensed somewhere else as a mental health provider, you can now cross the telehealth state lines to Connecticut and you won't be, you'll be in compliance. New Jersey just created a 24-hour turnaround on a one-page form. I applied yesterday morning and I got the notification of acceptance this morning, 180 days, and renewable as the situation calls for. So state by state, and your listservs would be a great place to find out from colleagues any up-to-the-minute changes on that.
Great, thank you. Yeah. And just briefly, we can talk a little bit more about sort of setting things up when we get into the exposure section of our talk today. But we wanted to just briefly mention how great telehealth can be for a lot of the work that you're doing, because it actually gets you into the child's home, and it can really get you kind of access to the child maybe in their most comfortable environment. So you may actually get them speaking a little bit more. Not always is that the case, but you can, you want to try to make sure that you're setting yourself up for success with the telehealth session. So you can actually, you know, kind of set up the camera so that you are at the distance that you want to be from the client, as well as you know, it really kind of depends on what you're doing with them, depending on how close you want to be. But you can really have them either have the camera right next to them, or you can have it further away. And you can also you can turn your camera off and still be, you know, verbal with them if your presence on the camera is too much, or even the family can, you know, they can kind of turn their camera or kind of even bend the screen down so that you're not actually, you can hear them, but you're not actually seeing them. So there's a lot of different ways to kind of control things and control sort of how much exposure they're getting at one time, just by positioning the camera. And it's nice, you can also use your phone to call them, or use the Bluetooth function, as many of us are doing here today, to coach them live in some of the exposures that you might be doing, because you have a direct connection straight to them, and the kid actually can't hear you speaking directly to the parent in their ear. So that's just a brief little note about setup. And then Katelyn, you were going to just briefly mention about insurance.
Yeah, so at Thriving Minds, we do participate with some insurances, and you know, I think we're running into the question of, can we bill insurance directly for telehealth services? And I think the short answer is we're not exactly sure. Some plans outright will say, yes, telehealth is a covered entity. Some have, you know, if you are participating through Teledoc, which is their internal system, will we accept telehealth services? Others are saying, we don't know yet. You know, I think that we're in a place right now where the more families are pushing for telehealth services to be covered, the more likely that will become. But right now, it's still a little bit up in the air, and it's very plan by plan specific. So if you are hoping to get telehealth services covered, I think being a squeaky wheel is a good idea here.
Yeah, great advice. Okay, so moving on to our next question. What are some ways that we can help clinicians keep working with their clients using telehealth, kind of on these multitude of factors here? So thinking through some exposure ideas. Aileen, Katelyn, everybody, I know we were all going to kind of jump in on this one, so this is the fun part.
Oh,
Can't hear you, Aileen.
Sorry about that. So I think
There we go.
this can still be a part of telehealth in this model. You just have to be a little creative about it. So using, teachers or extended family members. I know there's lots of schooling happening online. So if teachers are available and can join a session, you can facilitate them being able to speak and have like conversation with their teachers, asking for help about any material that they're having trouble with, kind of using this like online format to kind of bridge that gap between the school and the child, and you can be there to facilitate that when, obviously we're not able to go into the school environment now. And even with extended family members, if they're having trouble speaking with them, you can have them join the session, sending them those same links, and they can join and you can facilitate those interactions as well.
and I just would add that I think much like we would do in any of our practices, there's going to be a hierarchy of getting to the ultimate place. And so maybe the ultimate place or the ultimate goal is to be able to participate verbally in classroom e-learning activities or speak to a family member, and there likely are in like a little in between steps along the way, and being able to have that expectation as a clinician and then share that expectation with the parent, so that we're making stepwise small attainable goals and repeating them rather than just jumping for something that's probably like jumping a rung on a ladder.
Yeah, I know that Zoom has this like virtual like raising hand function. So if that's easier, they're just pressing a button and indicating that they want to raise their hand. That might be a good first step versus like actually physically raising their hand up on the screen.
Mm-hmm.
Yeah, exactly. Any other ideas for sort of with teachers or peers?
I was going to say, I definitely think that doing even just a test run with the teacher or peers first is again going to be maybe a step in the ladder, that even though teachers are becoming familiar with these platforms and are likely sending links to the family, again, just having a step of just testing it with the family without the child present, or even just testing with a neighbor, to again just sort of reduce those multiple variables, it's going to be really helpful. And maybe even just providing some tips, parent to other person, or even from the clinician, giving a few do's and don'ts to the other person so that they know what they should and should do and should avoid.
And just as a technique reminder, if we're taking a child who's never done this format of communicating with people, and we're trying to fade in a new person, that's changing two variables at once, likely to be problematic. So even the most concrete of things like, sweetie, I'm going to go into the living room and I'm going to jump on a different screen, and you can just practice going back and forth with me. Sweetie being a child, not my.
It could be in this day and age, who knows?
Yeah, and doing it with somebody that they're already comfortable speaking with. Yeah, that's a great point, Steve, so that you're only changing that one variable at a time.
And I think one of the things that was important for all of us to communicate to everybody was take chances, knowing that you can always put into context. If it's too difficult, we can take responsibility that we tried something, didn't work. Let's figure out how to break it down, so that willingness to be vulnerable, take a chance, see how it works.
Yeah, always doing those little baby steps kind of along the way. Yeah, Katelyn?
We're doing a lot, we're finding ourselves in the position where we're coaching parents and children, for that matter, through a lot of fade-ins and practices that are occurring outside of our specific sessions. And we're finding, there's a lot of great technology to support those goals too, like Marco Polo. There's a great app, oh gosh, I'm gonna blank on the name of it right now. Let me look it up on my phone. There's this great app that I just recently heard of. Of course, I can't find it. Caribou.
The good news is we can update people after.
Yeah.
Caribou,
Caribou
is the name of it.
Okay.
Yeah, but there's these great services like Caribou, for instance. You can do a puzzle together on the app, and it's also live recording and sharing video too. So built-in activities that can facilitate speech, which I think is really awesome that we have the luxury of those types of platforms.
I know we
Yeah,
didn't
and
plan
for people
to
who
do that.
don't know Marco Polo is like you can record these short little videos and then send it, but you're not actually communicating live back and forth, but you're sending a video. I mean, you can do it live, but you're really just sending these short little video clips. And like, what an amazing way for these kids to kind of get themselves moving and not feel that pressure of having to do it
and
live.
You can change your voice. You can alter your voice to be like a robot. You can also put little heart, emojis on it. So I think that things that add an element of fun is obviously going to be really helpful, and also decrease anxiety on everybody's part, because that kind of activity is just going to be more accessible.
Yeah, exactly. Steve, you were going to say something?
Just as a sort of interesting theoretical point, remember that the Norwegian CBT study was translated into defocused communication because they wanted to make sure kids and the therapist were like this, not like this. And just remember that when we go into this mode, it really emphasizes our eye contact to be aware of ways in which we can reduce that intensity.
Right.
Be aware of that.
And I think that's why the share function can be really helpful. So I know this is jumping a little bit, but we're working on getting our groups running and even making it available for those that aren't in our time zone, because usually we run group Friday at 4 o'clock, but we can make it available for other people. But again, with what Steve is saying, if we're sharing a screen in Zoom, like of a morning meeting schedule or a calendar, there's a little bit, I mean, I know we're not side by side, but there's a de-emphasis on this, which I think can be really kind of cool and helpful.
Another idea, not necessarily to do like during session, but to kind of promote like communicating with like their peers or family members. I know there's a Netflix party app that you kind of join and like group watch certain things. It's more of a chat feature, but you can all like watch a certain video or movie on Netflix and be talking about it. You can send like little like reactions and things like that as a way to keep like connected with like their peers and family members.
Yeah, so I think definitely encouraging families to set up, if it's these FaceTime play dates or kind of, even if they're just taking a couple minutes to send these videos back and forth to each other on Marco Polo, really kind of continuing that socialization aspect with their classmates, and kind of even participating in the classroom, as you were saying. And we can, since you had brought up the group treatment issue, Rachel, maybe we can skip to that and we can come back to a couple of the other ones. I know, at FIU, we're trying to get the groups up and running as well. And I know some of you talked about doing some joint sessions. So maybe you guys could talk a little bit about those.
Sure. Aileen, did you want to?
Sure, I can go first.
Go ahead, Aileen.
So the share function is obviously very great for that. Anyone can like annotate at the same time. So if you have a worksheet pulled up, everyone can kind of annotate and write their own, like type in their own notes of like things that their answers for their worksheets. And also Zoom has this really good feature. It's called like breakout rooms. So if any of the children at any time are kind of having a tough time participating, you can always create this breakout room where it kind of takes them and another kind of group facilitator in their own separate room, so they can maybe do some added practices or kind of get a sense of what kind of difficulty they're having before they're kind of reintegrated and can come back into the whole group. So I think that's a really nice feature.
That's awesome.
Yeah, and I agree. I think I just add the same thing, that some of the logistics are really more reaching out to families and making sure that they're obviously in agreement with the plan, which many families I think are just so eager to keep things going. I think one of the things that we're planning to do before we get our group going, again, to minimize that change in variables, we're assuming that kids may present differently when they're in this environment, even if they've been doing a certain way in live group. So we're just creating very brief, like tech check for parent, but also just almost like a reacclimation to someone they're familiar with, to just see how the child does just being on camera, use some CDI skills, meaning just some warm up without any expectation to speak, but just a check-in to minimize variables, almost explain what's going to happen in a child-friendly way, so that when we actually go live, we're just minimizing all the changes.
Yeah, great idea. I think, you know, another thing that you can also work on too is having sort of these joint sessions where, for example, again, a clinician within your practice, let's say if you have multiple people in your practice, you can, just like you would, you know, knock on their door and ask if they want to join, you know, if they're a client and you want to join their session, you can do kind of the same thing on Zoom or on another platform similar to that. And then you can also assign homework if the kids or the clients are willing and the parents are agreeing to it, you can assign for them to have a chat, you know, in their own, whatever platform they want to use, if it's FaceTime or these Marco Polo videos, whatever, that they would connect back and forth between the weeks of the session, so that, again, you're still kind of keeping that momentum going. So I think there's a lot of opportunity here for keeping it going. Just to hop back to presentations in front of others, there's also a really good opportunity, just like we're doing a presentation, you've got 5 people on the screen at one time and thinking about your client practicing reading aloud, and you can add people into the room by adding more people into your Zoom call as you need to, and you can really start and build your way up the hierarchy just as you would before. And then to briefly touch on the fade-in topic, as I mentioned before, I think the technology is really helpful for fade-ins, so that you can either you can still do a fade-in just as you would if you were walking by the door outside. So instead of me sitting right in front of my camera here, I would be over by my window, so I'd still be far enough away, and again, the kids would just be playing, and I can slowly move myself in. I can even keep the camera off until I'm closer to the camera, but still, you know, being verbal with them. Or if the family feels like that's going to be too much, then you can always have the family, you can keep your video feed off until the kid is really comfortable with things, or they can move closer and closer to their camera also. So I think you really have a nice kind of way in which you can use that technology to lead your fade-ins.
My colleague and I did a mock fade-in this morning. So one of her family members, I think it was her nephew, we did a little mock one online. And so, you know, I sat my chair all the way back at the far side of the room. I turned the other way with my book, and every so often I scooted a little bit closer. And I think it worked out really well. This was obviously a child who does not have selective mutism, was for demonstration purposes only, but I think that it worked out pretty well. And not, as you were saying, Jami, not much different at all from, you know, in the room, in person, fade-in.
Yeah, we've had a lot of success doing this with families who are coming, you know, from out of town for intensives or camps, things like that, where we want to at least get to know them a little bit online. And we've facilitated these fade-ins before, and it's been, I mean, it's very easy, and I feel like we do pretty well because they're also in their home environment where they're more comfortable too. So it gives us a little bit of a step up, I think. Let's talk a little bit about how this might look a little different between teens versus maybe younger kids. Aileen, I know we were talking about maybe you stepping in for that.
Yeah. So I think the games obviously look different, trying to be creative about like maybe like trivia games or like getting a sense of their interests and finding activities that they would like that you can use the share function. Also kind of using the co-host so that they can also have control over what they show you, and kind of using that to build rapport. It's like, okay, like you can show me like your favorite videos or TikToks that you're really into right now, or any activities that they're working on, video games, they can share that screen with you and show you like what the video game is about, and kind of use that to facilitate interaction and conversation. And depending on what stage you are in the treatment process, whether they're already speaking with you or not, I think you can always use the chat feature so they can type to you initially if that's going to be what's best starting off. Or when you're sharing like worksheets, they can write in like their answers and kind of working from there. So I know with some of my clients, I've used like sounds at first. So kind of using the closed mm-hms and mm-ms sounds to indicate yes and no, and kind of shaping and going up the ladder from there until they're able to give you maybe one-word responses and hopefully over time elaborating. So maybe writing their responses at first, but then practicing reading them out loud, things like that. Also, one other thing that I was realizing it was coming up more often is making sure they feel like wherever they're having their session is like a private space where no one's overhearing them. I think that's pretty important considering they're sharing some personal details with you. So making sure that the spot that they've chosen, like they feel like, you know, family members aren't around as much as possible. I know that can be limiting for some families, but trying to create this more like private space for them to have the sessions with you, I feel is really important.
Yeah, anybody else on that difference there? Okay. I know we were kind of talking amongst us also about that even if this isn't a time, you know, and I think Steve, you kind of said it best, even if this isn't a time for them making super gains, that really, we really want to help them just be coping well with the situation. Maybe you can expand a little bit on that.
I'm finding a lot of families I'm working with are just having trouble getting through the day. And so giving permission to ourselves and kids to just first stabilize before thinking about moving on makes sense to me. And I think, you know, our collective wisdom, we've never seen kids that just stop at a certain point, don't want to move forward. But right now, this is just a really strange time. So stabilizing right where they are may be actually just good enough.
Yeah.
Yeah,
I agree. And I think having that knowledge as a clinician, imparting that to families just again reinforces it, and saying it a lot is important. So we're continuing to make gains, and right now our job is to recalibrate and make sure it's okay to kind of hang where we are before we try to move ahead.
And I will say, going the other way, it's important to at least hang where we are, so that my families that are saying to me, we're just too overwhelmed to do this. This is the time kids need the kind of support that we as child psychologists and health therapists are really good at, even if it's just the more child-directed skills just to be supportive and relating. But this is not a time to decrease therapy context. I'm finding I have to decrease the length of all my sessions, but it's not time, in my opinion, to decrease the frequency at all. So frequent small touches, I think, make good sense.
Yeah.
yeah. Okay, great. And then last, regarding this, in terms of assessment, I think people are sort of figuring out whether to take on new clients or just stick with kind of the clients that they have. You know, we do a fair amount of telephone assessment coming through Florida at FIU, and but then also we can use other types of behavioral observation tasks, or Katelyn, I know you had mentioned getting videos from families. Maybe you can expand a little bit on that.
Yeah, so we have a lot of families that travel to us from quite a distance, and you know, we'd like to have some sense of what the kids' presentation at baseline is going to look like when they come to the clinic. So we do request that families send us a video of the child that they're most comfortable, and then if they can covertly find a way to record a time where the child is uncomfortable and struggling to speak, we really like to see that. We've been doing that for years, but I think it's more timely now than ever that if we can't be in person with a family, to do a direct observation in person, that's another great way to get that same information.
Great. Any other tips for assessment?
I would just say be both flexible and creative. So today I had a parent starting on a telehealth call just like this. I knew that the child was in the living room with siblings and a dad. And I asked her, just take the iPad with you and just go in, let's continue a conversation. We can talk about favorite cooking recipe or whatever, and let's just see what the impact is on your child, speaking with my joining you as sort of a pal. So I think being creative and flexible makes good sense.
Yeah, it's a great idea. I think one thing that I didn't mention in the beginning about getting that consent is always making sure that you have a backup contact information for them. So if you lose connection through telehealth, that you have a phone number, you have the phones nearby. I would recommend you always making sure that they have their phone nearby. You know, we have done a lot of telehealth studies at FIU, and the biggest thing I can say is that throughout all of this, you're going to have some tech failures. So have the phone nearby, make sure you can reach out to them and connect, because even if you can't continue to coach this way, you can coach over the phone, or you can connect to them over the phone. And they have, again, if you need to use FaceTime, then at least you might still have that option to connect. So I think get that backup contact information, and I think you can, again, really be creative with the assessment piece.
And I think especially for new patients.
Can I quickly add, we're using, I was just gonna say, we're using like the Google Voice service, so it can kind of populate a fake phone number, if you will, right? So you don't have to give out your personal cell phone, and yet you're still able to connect with the families in that way too.
Yeah, great. Rachel, you had something to add?
Yeah, I was just going to say for new assessments especially, and maybe not so much with this population, but when you're meeting new patients, you want to verify their address and make sure that is where they are, and that backup just in case you have any items related to risk. You just want to have that information, know where a family is, and just know a backup number in case you need to reach them in an emergency.
I smile all the time, but I was just smiling because I lost you all for half a minute. So I'm thinking how propitious given the presence.
Yep,
and we didn't notice.
It's gonna happen, yeah. Before we get to some of these typical barriers, one last thing that I realized that we wanted to touch upon was kind of keeping, you know, a lot of times we get these great reinforcement systems set up, and maybe we can talk a little bit about how you can keep those consistent throughout this sort of difficult time. Aileen, Steve?
So I think, first of all, my reinforcements with families I'm working with are changing now, because what the currency is that they have available is changing. A lot of families in the inner city have moved out to friends and family who live out of dense areas. So whatever the rewards were may not be available now. And I personally always emphasize the role of social reinforcers more than thing reinforcers.
Yep. Yeah, for sure. And I think you can get really creative here. And I think sometimes some families and clinicians are really good about being creative and some aren't. So having like a list of things can be really helpful. And for my son, I'm just keeping track every day when schoolwork is done with little emojis in a notepad function on my phone, and then rewards after he gets X amount of emojis, which is, again, not very hard to do.
Yeah, it can be things like getting to pick out like the dessert or what the family's gonna have for a meal. It could be like picking out the movie or a game for like family night, like things like that don't, require any kind of buying of prizes, which we obviously can't do in this, it's not an essential activity to be going out and doing right now.
Yeah, you can even use a Google Doc if there's no identifying information on it to, again, kind of share a document that you can work on in real time. If there's like we've made, reward banks at least for your sessions with the clinician to use as they go along, so they can kind of keep track as to where they are. Again, you can use those for hierarchies, things like that, something that they can also have access to. Again, not that that has any PHI in it, but again, something that you would be able to work on in the same time, and both have the function to modify it if you needed to. So let's move on to some typical barriers or kind of trouble spots that we might see along the way, and how we might address those. So the first is technology. So as you've clearly seen, we've had some people kind of pop in and out. You can't hear somebody. So these things, again, are going to happen. And I think again, we've kind of addressed this. Keep that phone handy. Keep those backup, numbers handy. And sort of, I think, Rachel really talked about this in terms of getting it set up in advance and really letting the parents know that these things might happen. That's okay. We kind of all expect that to happen every now and then. And to think through how you might be able to minimize those. So again, don't expect that it's not going to happen ever, but how can you try to minimize that as much as possible? Rachel, you want to talk about some of the other ones?
Yeah, I was going to say also just in terms of the tech, but also just anxiety that could be in the room on the clinician's part or the family, just modeling non-anxious coping is so important. So when Steve was not audible for a minute, I didn't really notice. So he looked calm. We were all trying to portray a good exterior, which means that, some of us are having great days today, some of us might not be. And at the same time, we're trying to model non-anxious coping. And so we as clinicians should be doing that. We should be encouraging our families to do that, right? And so just managing those tech barriers and some of the other barriers Jamie and I talked about were, is the child staying in the room and engaged in the activity? And I think similar to what we might do in the office, if I can think of a session where maybe the child is not interested in the particular activity or maybe is avoiding in the situation because there's some kind of speaking demand. And again, coaching parents through what skills to use to act very interested in the activity, engage with the clinician, and then reinforce positively re-engagement in the activity rather than start some kind of back and forth negotiation, like, why aren't you over here? Jamie's here. It's so fun when she's here. Because those are strategies we wouldn't do in the office. And so we really want to model that.
Yeah, I think one other helpful thing that we learned kind of along the way doing some PCIT with little disruptive kids was to try to actually minimize the amount of distraction in the room, which at a house is really hard to do, right? You bring them into your office and you can try to get rid of as much stuff as you can. At home, that's a little harder to do, except to try to find a room that might have the least amount of distractions possible for them. And that may vary per kid, but and try to go into that room, maybe close the door to that room so that, again, your focus is on having the session and really making it that time, just like they would if you were getting them into the office. And that way, maybe bringing in some things that that they like to do so that they have those there to show the clinician. But again, helpful for them to kind of be a little bit separate from what's going on in the rest of the house and those distractions.
I would also add like two other things that we've talked about, and is volume and age. And I think with volume, that's likely and certainly possible that the child might be engaged and speaking and volume may be an issue. And I think that if you're working directly with a parent in the room, that's a great opportunity for them to practice their reflecting skills, because if the child says, the child says, and the parent says blue, then you can say it is blue. And that's just a great coaching moment. I also think that if you were, for example, in a group or in a dyad and you didn't have the parent directly there, I still think there are probably workarounds in terms of, I love hearing your voice, even if you're not reflecting what the child said, or you might say, use a good, instruction, like one, that was great, telling me one more time a little bit louder. So I don't think that volume has to be a rate limiting factor at all. And I also think that age, we want to keep that in mind, age and more stamina and, developmental level, whether it's chronologic age or otherwise, that, a parent might have an hour to work with you and a 4-year-old might not be able to sit in front of a computer for an hour. And again, as Steve said, sort of being kind to ourselves, managing expectations, 30 successful minutes to me, or 20, are better than 60 like drawn out minutes. And in fact, I would argue that that's not helpful at all. And I would manage the expectations in a variety of ways by saying, like, this is what we're going to do. This is going to be a useful chunk of time. So those are some of the other things that could be barriers, but we can navigate to our advantage.
Another thing with volume that I think like technology can be helpful with is like if you have a headset, there's always the microphone is a lot closer than if they didn't have any kind of headset. The voice has to travel quite a bit. Some like teens have those like video game like headsets with the speaker right there. Those are helpful too. So if they have those kinds of things, you can definitely use them as a way to help with volume issues.
Yeah, one other thing.
And I think you can always fault technology. You can always fault the technology, right? It skipped. I couldn't quite hear you. I saw your mouth move, but I didn't hear what you said.
Right.
Yeah, that's a good thing. I think too, like if you know that you're going to need to check in with the parent to see how things have been going, or that you need to talk to the parent about something, tell the parent in advance so that the kid is off doing something else, so that you're not having the kid sitting right here next to you, like twiddling his thumbs and getting really irritated because they're sitting there. Whereas maybe in the office you have somebody else playing with them, but at home, let them go do something else and then only have the parent bring them over when it's time for them to join the session, so that they can be, you know, hopefully as engaged as possible once session time hits. Okay, so I
also just think like a last comment about parent anxiety, which is, I think, especially for parents who might be anxious right now due to some of the you know, the situational factors, which I think all of us are experiencing, but maybe anxiety directly related to the treatment. It's just so important to manage those expectations and try to address any anxiety off a coaching call, off a video call. And again, I think just using a lot of compassion and normalizing what is going on right now, and also explaining why modeling non-anxious coping and having appropriate expectations is just going to be so important and helpful ultimately for the child and their treatment.
Yeah, so Rachel, you just like set yourself up for this amazing.
I set myself up. Yeah, I think we kind of talked about this a little bit, but I just think that managing expectations is really important. And again, we talked about this already in terms of what are our goals. Stabilization is really important first, and not just in service of getting to the goal, but is important in and of itself. And just outlining that is really important. I also think, you know, Steve and we were like talking about yesterday, this idea of this being really a marathon and not a sprint. And so if we're just prepping for this week, that's not going to help us for the, you know, the immediate short term. And so just again, like reinforcing the stamina and the importance of kind of staying where we are, where Steve was saying, like, we don't necessarily need to make leaps and gains, but we also still need to be doing what, at least a minimum of where we were, so that we can continue to kind of promote stabilization and recalibrating. And then I think just again, this idea of like a lapse and a regression, I think we again already talked about that, but when I hear regression, my ears like immediately perk up and I have like a very strong reaction to it, because we're all experiencing so much right now that it's reasonable to have good days and bad days, or a great productive session or a so-so session. And I would take those as all grist for the mill and not categorize it as a regression.
Developmental psychologists talk to us about regression in service of the ego, which means sometimes based on what's going on around you, you need to just take a step back and you're not going to be as organized. I'm begging my team to remind me more because I'm forgetful about important details, and our kids are going to respond the same way, except I'm an adult and I can say I'm feeling quite overwhelmed, and our kids are going to show that in their behavior. So a compassionate approach, what we all encourage.
Yeah.
Yeah, definitely. I think the last thing that we really wanted to emphasize is sort of clinicians making sure that they're taking care of themselves, and, you know, as psychologists, as, you know, clinicians, really just managing your own self-care during this time. So given Steve, you segued, so again, you guys are just leading right into your own, this is great. So Steve, maybe you can talk a little bit about, again, making sure that that self-care is happening.
You know, other than encouraging that we actually take time every day to do something that's not responsible for the rest of the world. One of the things I say to my wife is, who heals the healers? And, you know, taking time for that walk for ourselves, to have a fire pit if you have a fire pit, and just do something daily that is away from the work. Rachel enjoyed my automatic message, which says, for self-care reasons, I'm not returning emails after 7. I'll get to you tomorrow. And I listed my cell phone because my patients, I'm fine with that. So I think just clarifying your boundaries, but making sure you have some downtime is really key. This is going to go on for a bit of a while.
Yeah. And I think just finding your village is so important, and defining that village. So we all have our own personal villages, but we can be part of lots of them. So, you know, whether it's your own child, if you have one, their grade at school, you might be part of that village, or your family's village, or this village, and those connections. What? Say it again?
You guys are my village.
And you're ours. But I think that actually is very like life sustaining, and actually gives me personally great comfort, and I feel them very genuinely. So I think those connections are really important to keep us connected as clinicians or parents or spouses or friends. I think, and for those of us who are in helping professions, we will burn out if we don't. And so I think we have to take a bit of our own medicine that we're giving out.
Yeah, definitely. I think there's a lot of additional resources and trainings and things that are offered as well. You know, one being, if anybody's on the SMA professional listserv, I think I'm echoing at this point. This is again a technology problem that you can. I know a group got together and created a great list of different types of games and exposures and things, which was amazing. Everybody got together and then sent that out for everyone else to use. And again, I think it's times like this where, again, if you think about it, we're all in this together. And I think, again, relying on your colleagues and again, this greater village of SMA, we're here to support you guys and to help as much as we can. So if there's additional things that you would like webinars on, again, let us know. We're just trying to think about how we can best help support all the clinicians and families that are coming through this time right now. In the handouts that will be attached to the video, there's a whole host of different resources, different websites and links that you can go to for additional trainings, as well as other information on other types of telehealth trainings and resources. So again, if you need anything, you can always email our main email address, or visit our website. And we just really hope that you all stay safe. And I'm echoing.
We hear you okay, Jami.
All right. So thank you, everybody. Thank you, Aileen, Katelyn, Rachel, and thank you, everybody. Please stay healthy out there and let us know if we can be of help. Thank you, everybody.